so we stay on time and we respect the time. So I would say if it's 7:30, we start.
And we'll each share our own screens. Is that how we're going to do this with our slides?
Correct.
Correct.
Thank you.
Maybe Fadl, you can share the program with us on the chat.
Okay. Sure. Okay. Sure. I'll do that. Let me just start the recording and start the webinar. Just 1 second.
Okay, I got it. All right. So Fawaz, you're the first speaker, so I'll just introduce you and we'll just, and then you can introduce Batul and Batul can introduce Herb. So I think we can just move along.
Good.
Fadl, we are ready?
Yes, we are ready now.
Okay. Shall we start?
I think we should, if we want to stick to the time.
Yeah, I think we should start. So welcome everybody to the Peripheral Arterial Disease Guidelines. Our chairman, Dr. Mervat Alasnaj, is in a flight, so she wishes us luck. And it is my great pleasure to introduce my friend Fawaz Bardoli from Bahrain to give his first case presentation. And we will follow along after that. Thank you.
Yeah.
Fawaz.
Thank you, Waqar. Welcome everyone to this webinar. The idea of this webinar is to kick it with a very nice, interesting case that will probably stimulate the discussion afterwards. So without further delay, I'm going to show a case that probably will be interesting for everyone. If you don't mind, if you just can confirm to me if you can see my screen very well. I'm going to put it on the slideshow now. Can you see the slide?
Yes, we can.
Good. All right, thanks. So, so I'm going to start this case of an 80-year-old male who has an impaired glucose tolerance, hypothyroid, on thyroxine, chronic smoker, COPD on multiple inhalers, ischemic heart disease with reduced ejection fraction, multiple intervention in the past. He was actually referred to me with classical right lower limb claudication syndrome from a colleague vascular surgeon. So he has performed to him the CT and sent him to me with a CT that showed very clearly that the right side of the SFA is completely occluded with some disease in the left side. However, the iliacs were free of significant disease. So I've seen the patient first in the clinic. He's a very good 80 years old, active, goes to the mosque, do his own shoppings. His cholesterol, mainly the LDL, was around 3 with HbA1c of around 6. His ABI, calculated on the right side, ranges between 0.4 and 0.5. The patient was initially on aspirin and Lipitor, atorvastatin 40. When I saw him, because of the high LDL, so I tried to optimize his medication, including adding the ezetimibe and ACE inhibitor. And I've explained to him the options that we can go forward from here. So medical therapy versus an intervention in the future. So I give the patient a month or so, and then on the medical therapy, with encouraging him to do some exercise as well. However, the patient comes after 2 months with still claudicant, and this claudication is actually limiting his daily activities and limiting him being very active like what he used to be, as his son was stating. So from that perspective, I took the patient to the cath lab, and I started with an access from the contralateral side, knowing that the occlusion is on the right SFA. And when I perform this, these are the findings that you will be seeing. So the right SFA is completely occluded from the ostium. It reconstitutes later at the popliteal level. And I just show you the one in the middle, which is a different angulation that you can see a bit of the ostium of the SFA. As a routine, I do as well the full leg assessment. So you can see that the P2 and P3 things are fine at the popliteal, with probably an occlusion at the posterior tibial artery as well. The foot circulation at the lateral plantar is preserved from the dorsalis pedis in the middle picture. So let me just run this. Yeah, there you go. So I would probably stop here and listen to the panel discussion here of what would you do at this time, whether you want to discuss it now or you want us to go further with Batul's presentation on the guidelines and we take it further. Thank you.
I think it might be really nice to hear a little bit about the guidelines, and then, using this case as a context, apply them after the fact, if others like that idea.
Yeah, I agree.
I agree with her.
So if you don't mind, Batul, if you can go ahead with your presentation, please.
Yeah, sure, absolutely. So I'm sharing my screen right now.
Fawaz, you have to unshare your screen probably. Yeah.
Okay. Can you guys see my screen?
Yeah, perfect.
Okay, so today I'm going to be talking about what's new in the 2024 AHA-ACC PAD guidelines. I have no disclosures for this talk. For starters, I want to stress on the importance of PAD and why is this condition really important for us to diagnose, to manage, and to prevent like worsening outcomes or prognosis in those patients. For starters, PAD is a significant global health burden. In the Western population, it has been reported to affect 3 to 10% of adults, whereas in Asia and other developing countries, prevalence rates can exceed 20%. However, when it comes to discussing the prevalence and the epidemiology of PAD, there are a couple of challenges that have been faced. One of those challenges is that a lot of patients who do have PAD are asymptomatic. And the other challenge is that a lot of patients who do have PAD are patients with limited healthcare access, or they are residing in areas that are underprivileged. And therefore, PAD is underdiagnosed. Now, it's really important for early detection and comprehensive management of this condition because PAD has been linked with high risk of major adverse cardiovascular and limb events. And therefore, in the 2024 ACC-AHA Multi-Society Guidelines, for PAD that have been published in May of this year, there has been special emphasis that PAD is a common cardiovascular disease, which is associated with increased risk of amputation, myocardial infarction, stroke, death, as well as impaired quality of life, walking performance, and functional status. And this is where the huge emphasis has been highlighted on early detection and management of this condition. Now, when it comes to early detection and screening for PAD, it has been recommended that in patients with history or physical exam that is suggestive of PAD, such as a patient who would walk into your clinic with a complaint of lower extremity cramps, claudications, pain when they walk for long distances, or even any evidence on physical exam that they may have decreased perfusion to the lower extremities, obtaining a resting ABI is recommended for the diagnosis. In addition, patients who are at increased risk of PAD, such as patients that have risk factors like diabetes, hypertension, smoking, multiple polyvascular disease, screening for PAD with a resting ABI is also a class 2A recommendation. On the other hand, patients who have suspected CLTI, we could either use toe brachial index or toe pressure with waveforms, transcutaneous oxygen pressure, and or skin perfusion pressure in addition to an ABI for the diagnosis. Now, it's really important to highlight the fact that when evaluating patients with PAD, guidelines recommended that clinicians should assess for and incorporate the presence of PAD risk amplifiers when developing a patient-focused treatment recommendation. And those amplifiers, they include the race, the gender, the ethnicity, the geographic factors, social determinants of health, diabetes, smoking, chronic kidney disease, polyvascular disease, and macrovascular disease and depression. And this also brings us back to the importance of risk factor modification or risk factor reduction. Now, as I mentioned earlier, PAD is associated with increased risk of MACE in male, but when it comes to MACE, the relationship between PAD and MACE is very well established. Matter of fact, we know that patients who do have PAD have 2 to 6 fold increased risk of having a stroke or myocardial infarction compared to those that do not. And therefore, especially in the patients that have known underlying risk factors like multivascular atherosclerosis or polyvascular disease, hypertension, diabetes, chronic kidney disease, and smoking, the guidelines emphasize the importance of this risk factor modification in this population. So how can that be done? For starters, for hyperlipidemia management, the guidelines recommended high-intensity statins for all PAD patients, aiming to achieve a more than 50% reduction in their LDL. Now, add-on options including PCSK9s or ezetimibe in case the patient's LDL is greater than 70. For blood pressure control, the target blood pressure for this patient population has been recommended to be less than 130 over 80 millimeters of mercury. The preferred medication would be ACE or ARBs because they are known to have reduced MACE. Diabetes management recommendations was for the use of GLP-1 receptor agonists or SGLT2 inhibitors in this patient population, in addition to stressing on the importance of smoking cessation in those patients. Now, when it comes to antithrombotic or antiplatelet therapy, the guidelines takeaway on this matter is if the patients do have symptomatic PAD, then a single use of antiplatelet therapy is recommended. So we could either use aspirin or clopidogrel. For patients who do have symptomatic PAD and they are undergoing endovascular or surgical revascularization, we could use low-dose rivaroxaban together with an aspirin. And for patients who have PAD but do not have any other indications for anticoagulation, the guidelines mention that full intensity oral anticoagulation should not be used only for the reason to reduce the risk of MACE and MALE. Now, when it comes to structured exercise program, we all know how important this program is in improving the functional status of those patients. Therefore, based on the guidelines, patients who have chronic symptomatic PAD, supervised exercise or structural community-based exercise program with behavioral techniques is recommended to improve the walking performance, functional status, and the quality of life. Now, alternative programs have been mentioned in the guidelines. However, those alternative programs, like the use of those alternative programs has been stated as class 2A, a level of evidence for patients who do have PAD. Now, I know all of us who ask patients to do the structural exercise program in setting of PAD know the challenges that we face in this context, especially when it comes to patients' compliance and to insurance coverage for this program. Now, talking about revascularization and limb care, which also circles us back to the case that Fawaz just mentioned, based on the guidelines, revascularization is recommended for patients who have CLTI in order to preserve limbs and to heal wounds, and for patients who do have resting claudications or collocations that are not really responding to any exercise or medication. In addition to that, the guidelines stressed on routine food care, wound care, preventive measures, patients' education, and the importance of other healthcare professionals like podiatrists and physical therapy in taking care of those patients within this population. Now, to dig a little bit deeper in revascularization, based on the guidelines, it has been recommended that if the patient has asymptomatic PAD, it's reasonable to perform revascularization procedures only if there is another condition or another procedure which is actually needed, like a TAVR that is practically needed. So it's more like optimizing a patient for this procedure. However, revascularization in this patient's population, which is asymptomatic PAD, should not be performed only to prevent the progression of the disease. Now, in patients who do have functionally limiting claudications and they have inadequate response to medical therapy, including the structured exercise program, revascularization is reasonable and could be a treatment option in order to improve their quality of life and their walking function. Patients with CLTI, as I mentioned earlier, revascularization could be essential in order to minimize the tissue loss, heal the wounds, relieve the pain, and preserve the function of the limb. And patients who do have CLTI and ischemic rest pain from multi-level arterial disease, it's reasonable to revascularize to address the inflow disease first. Another thing that the guidelines have stressed on is health disparities when it comes to PAD. Now, we do know that PAD has a lot of healthcare burdens and social burdens, including increase of the healthcare costs and also worsening complications that could impair patients' quality of life and functional ability. And therefore, in those guidelines, there has been a very particular focus on the importance to address racial and ethnic disparities in PAD diagnosis and treatment, particularly in patients who are in underprivileged areas or patients who have limited access to healthcare, and they may have higher rates of advanced disease and amputations. So those are the references that I used in my presentation. And that's it for today. I'm gonna stop sharing. And I'm gonna go ahead and introduce someone who actually means a lot to me. So the next speaker is going to be Dr. Herb Arno. So Dr. Herb is currently, he is the medical director of the Heart and Vascular Services at Henry Ford Health, where he oversees cardiovascular medicine, cardiac surgery, and vascular surgery for the health system's 5 hospitals. Dr. Herb has completed his undergrad medical school and public health studies, as well as his internal medicine residency at the University of Michigan, and his cardiovascular medicine and intervascular cardiology fellowship at the Cleveland Clinic. He has more than 200 peer-reviewed original articles, editorials, chapters, and reviews. And he has been the SVM president, actually the longest serving SVM president for a very long period of time. And today he is going to talk to us about the guidelines, the 2024 ACC-AHA guidelines compared to the ECS-PAD guidelines.
Thank you for that really nice introduction, Batul, and thank you for the honor of joining you on the webinar today. I, as you just heard, was the vice chair of the writing group for the 2024 ACC-AHA guidelines. And I was asked today to talk about how those are similar and how they differ from the ESC-PAD guidelines released the same year. There are 2 pictures, 2 graphics on this title slide, and I think these kind of highlight the task that I have before me. I think you'll all agree that both are black and white. I think you'll agree that on the left there's an animal and on the right there's a woman. But interestingly, you may have different perspectives on what you're seeing. On the left, some of you may see a duck with its bill pointed toward the upper left. And others may look at the same image and actually see a rabbit with its ears pointed toward the left. On the right side of the slide, some of you see a younger woman with her head turned to the right. You're seeing her in profile, and others may be seeing an older woman with a prominent nose and chin, both wearing bonnets. Now, how is this possible? We're all seeing the same information, but yet we're reaching different conclusions about what we're seeing. So again, I think that's the task upon me today when we look at all of us looking at the same evidence base and yet in some examples reaching different conclusions about how strong the recommendation should be for what we do for patients with peripheral artery disease. So with that, I will move on. These are my disclosures. I want to start out with how we grade the guidelines. The good news is that both the ACC/AHA and the ESC documents use a similar approach and a similar color coding. That makes it easy for us today, I think, when we look at the slides, because I've color coded them throughout. Class 1 is the strongest recommendation behind something, and both sets of the US and the European use that. Both also have Class 2A and Class 2B, which are sort of moderate and weaker recommendations. And both also use the nomenclature Class 3, which is usually something where there's either a harm or there's just no evidence base to support something. There is some variability in the level of evidence required to be considered A, B, or C, from highest to lowest, and how those are categorized. But I think overall, as I mentioned a moment ago, the schema for classifying these recommendations is fairly consistent. The scope of the guidelines is somewhat different, though. So the ACC/AHA focuses exclusively on atherosclerotic lower extremity peripheral artery disease, whereas the ESC document is broader. It looks at non-atherosclerotic lower extremity peripheral artery disease, at carotid stenosis, at renal and mesenteric stenosis, and even at aortic disease. Most of my presentation, or really all of my presentation from here forward, is going to focus on the atherosclerotic lower extremity PAD, the overlap area. I'm sorry, was there a question? There are areas that were common to these two guidelines, and those are clinical manifestations, diagnostic testing, medical therapy, exercise therapy, and revascularization. And I'm going to run through where the guidelines agreed and disagreed as far as recommendations were concerned in just a moment. Both sets of guidelines classify patients into one of four groups: asymptomatic, chronic symptomatic, the ACC/AHA calls the next category. Those would be patients with claudication, like the case we heard about. Chronic limb-threatening ischemia, or CLTI, formerly referred to as critical limb ischemia, or CLI. Those are the same thing, just a newer terminology. And finally, acute limb ischemia, or ALI. The ESC guideline uses the same four categories: asymptomatic, they call the next symptomatic, not chronic symptomatic, and then CLTI and ALI. So I think this makes it easier for us that we're looking at the same disease states. So let's start with diagnostic testing. And as I move through these guidelines, you're going to recognize some of them because Batul just did a really wonderful job reviewing what the ACC/AHA document recommends. But I think what's unique here is that we're going to contrast that with where the ESC document was. So the ankle brachial index, or ABI, to be used as a screening tool in those at risk for PAD, is given a Class 2A recommendation in the US document, but not graded, although supported in the ESC document. When it comes to actually establishing a diagnosis, the ABI is given a Class 1 recommendation by both guidelines. The recommendations around duplex ultrasound, or DUS, vary slightly. So to confirm the diagnosis, the ACC/AHA guidelines suggest that if there's uncertainty, that it's reasonable to go ahead and do this. If there's a Class 2B recommendation afforded, the same thing is true in the ACC/AHA guidelines with respect to CT angiography and MRA angiography when it comes to confirming diagnoses. In contrast, duplex ultrasound is actually given a Class 1 recommendation for confirming the diagnosis. So pretty routine, if you will, in the ESC document. And CTA and MRA are not graded. There's no comment about use of them for confirmation of diagnosis. Doppler ultrasound and CTA and MRA are all given Class 1 recommendations in the US guidelines to inform revascularization. That is both decisions about revascularization and perhaps revascularization modality that would be preferred. Whereas in the ESC document, it's a 2A recommendation, 2A class of recommendation to use duplex to inform revascularization, but a Class 1 for non-invasive angiography. And then finally, invasive angiography is given a Class 1 recommendation in the ACC/AHA document to inform revascularization, but is not graded in the ESC document. Moving on to antithrombotic therapy, and when I say that, I mean antiplatelet and/or anticoagulant agents. Again, you've heard from Batul about the ACC/AHA side of that. SAPT, or single antiplatelet therapy, for those who have PAD and are symptomatic, has a Class 1 recommendation in both guidelines. If you are asymptomatic, or your patient is, Giving SAPT has a class 2A recommendation in the ACC/AHA, but actually a class 3 recommendation in the ESC. Not that it's harmful, but felt not to be beneficial unless, of course, you have diabetes, in which case the ESC afforded a class 2B recommendation. After revascularization, single antiplatelet therapy was given a class 1 recommendation in both sets of guidelines. Now, DAPT, or dual antiplatelet therapy, is given a class 2B recommendation for patients with symptomatic PAD in the US guidelines, and a class 3 for the ESC. In patients who are asymptomatic, there was no grading on the US side, but the European document afforded a class 3 recommendation. After revascularization, DAPT gets a 2A class of recommendation in both sets of guidelines, although it's recommended for anywhere between 1 to 6 months after endovascular therapy, specifically in the ACC/AHA document, and 1 to 3 months after any revascularization in the ESC document. And then finally, dual pathway inhibition, in other words, low-dose aspirin plus low-dose rivaroxaban in patients who are either symptomatic with PAD or who are post-revascularization. We gave that a class 1 recommendation in the ACC/AHA document, but in the ESC document, it's a class 2A. Moving on to cholesterol, blood pressure, smoking, and diabetes, high-intensity statins, as you heard a moment ago, are recommended as class 1 to reduce LDL by at least 50%, although the target LDL cholesterol levels differ in the US and European guidelines. It's less than 70 milligrams per deciliter in the US and less than 55 in the ESC guidelines. Adding ezetimibe if the patient's still above the cholesterol goal, and adding a PCSK9 inhibitor in the same scenario are afforded a class 2A recommendation in the ACC/AHA guidelines, but a class 1 recommendation in the ESC guidelines. We all agree that antihypertensive therapy should be administered to a target blood pressure, and that carries a class 1 recommendation. That target includes both systolic and diastolic blood pressures in the ACC/AHA guideline, less than 130/80. And in the ESC document, it specifically targets systolic blood pressure and recommends a range of 120 to 129 millimeters of mercury. ACE inhibitors and angiotensin receptor blockers as first-line therapy for hypertension, as you heard a moment ago, are class 1 in the ACC/AHA document, but class 2A in the ESC document. Smoking cessation using counseling and pharmacotherapy carries a class 1 recommendation in both documents. Avoiding secondhand smoke also carries a class 1 recommendation in the US document, but a class 2A in the European document. Now, diabetes. Getting hemoglobin A1C to target isn't graded in the ACC/AHA document, but is given a class 1 recommendation in the ESC document, which suggests that the hemoglobin A1C should be below 7%. And then finally, SGLT2 inhibitors and GLP-1 receptor agonists in patients with diabetes and PAD are given class 1 recommendations in both documents. Exercise therapy for what's referred to as chronic symptomatic in the ACC/AHA document or symptomatic in the ESC document. Oftentimes, this is claudication. If we look at supervised exercise therapy, that's given a class 1 recommendation in both documents. Other modes like community or other locations like community or home-based exercise are given a class 1 recommendation in the ACC/AHA guidelines, albeit after first attempting or recommending supervised exercise therapy, but in the ESC document given a class 2A. Both documents recommend that with endovascular revascularization, that exercise therapy also be administered as an adjunct. Walking is preferred as the modality of choice. Otherwise, if not possible, other non-walking modalities could be employed. Both guidelines give that a class 2A recommendation. Both guidelines also suggest 30-minute sessions at least 3 times a week for 12 weeks and support this, but don't afford a formal recommendation. When it comes to revascularization for chronic symptomatic or symptomatic disease, both guideline documents agree no revascularization. That's class 3 for those who are asymptomatic, with the exceptions that Batul noted a moment ago. Revascularization after failed guideline-directed medical therapy or GDMT, including SET or structured exercise therapy, well, that gets a 2A recommendation, revascularization, a 2A recommendation in the ACC/AHA, but a 2B recommendation in the ESC document. If there is aortoiliac disease and there's an indication for revascularization, there's a class 1 recommendation for endovascular therapy and a class 2A for surgery in the ACC-AHA document. If there's common femoral disease and revascularization is indicated, endovascular therapy gets a class 2B and surgery a class 2A recommendation in the ACC-AHA document, but neither aortoiliac revasc or common femoral revasc is called out specifically with formal recommendations around which modality of revascularization in the ESC document. If FEMPOP revascularization is indicated, there's a class 1 indication for endovascular therapy and a class 2A for surgery in the US document, but a class 2A for both in the European Society of Cardiology document. And then finally, revascularization of infrapalpiteal arteries at the time of revascularizing more upstream disease carries a class 2B in both documents. What about for CLTI or chronic limb-threatening ischemia? Class 1 recommendation from both documents for employing a multi-specialty care team. Class 1 in both documents for revascularization with the intent to salvage the limb. Endovascular as first-line therapy and surgery as first-line therapy in this setting were afforded class 1 recommendations in the US guideline based on the BASIL-A and BASIL 2 trials. But given a class 2B recommendation in the ESC. So again, I think the ESC stressing that perhaps it wasn't as clear whether one was better than the other from these two trials I just alluded to. If surgery is going to be performed, bypass surgery, autogenous vein to be used as a conduit is given a class 1 recommendation of both documents. If there are ulcers present, offloading is recommended as a class 1 in both documents, although the US document specifies that this should be for diabetic foot ulcers, that there's less evidence base to support non-diabetic ulcers. And then finally, antibiotics and wound care are given class 1 recommendations in both guideline documents. And that takes us to ALI, or acute limb ischemia. Both documents give a class 1 for urgent or emergent evaluation for limb viability by a specialist who's qualified to assess viability. Unfractionated heparin, interestingly, is given a class 1 recommendation in the US guideline and a 2B in the ESC guideline. Urgent revascularization is class 1 in both, and monitoring or treating for compartment syndrome is given a class 1 in both. So in conclusion, the ACC-AHA and ESC guidelines classify recommendations similarly, although the levels of evidence to support these vary somewhat. Both guidelines cover PAD clinical manifestations, diagnostic testing, medical therapy, exercise, and revascularization. The ACC-AHA guidelines focus exclusively on low extremity PAD, specifically atherosclerotic disease, while the ESC guidelines include carotid aorta, renal and mesenteric, and even non-atherosclerotic lower extremity PAD. Both guidelines provide guidance on the spectrum of PAD manifestations, including patients who are asymptomatic, who have chronic symptoms, CLTI, and or ALI. Both represent excellent tools to inform everyday practice. Thanks very much.
Thank you so much. Maybe we should go to Fawaz's case and see how he dealt with it in light of these excellent presentations on guidelines.
Thank you, Okhar. Thank you, Dr. Herb. I hope I stick to the guidelines that Betul also guide us to. We'll see what would happen now. So let me just share with you the again the presentation. So, when we reach to this level now that we have a significant or complete occlusion of the right SFA in symptomatic patient, the question number 1, should we continue medical therapy? But I think this is not a very good option now. We put him on medical therapy for 2 months and still he's symptomatic. Exercise therapy, yes, it is a fantastic option, but as Betul stated before, we have a lot of difficulty in doing this and monitoring this. We don't have, at least in Bahrain, we don't have the good center that we perform this and follow this. Surgical revascularization, well, the patient has been sent from the vascular surgeons because he doesn't want to touch an 80 years old with poor ejection fraction and COPD. So we left with revascularization endovascular. So this is another view now, just to know the baseline of what's happening here. So we have the common femoral, and I'm trying to negotiate in this picture number 2 with a microcatheter through a crossover sheath and an 018 wire, which you can see it goes all the way straight. Then I took a smaller microcatheter and tried to go in a loop direction further all the way to a limit, which you can see it in the 4th picture here, all the way antegrade up to the level of 30, 35. I don't want to go further than that because once you go into the loop, then the question is probably you are in subintimal space. Further to this, using the digital subtraction and guide you, some people call it DSA mask. So my wire is up to this level 45, and I know the connection is at around 45, so I don't want to go further. Now you can see from the second picture here that my wire goes into some of the collaterals, which gives me sort of like a confidence that I am in the intraluminal space. But unfortunately, I've tried multiple wires, de-escalate that to an 014 wires, and then I start switching on my time. I don't want to spend more time trying to go into this further. I've given myself a small chance with the loop there, but I have seen that the loop is going actually against subintimal, that you will see it here. Then I stopped this, and I always time myself that I give myself a chance, and the antegrade if failed, then I stop. I don't go further because then I will just extend the subintimal space through the antegrade approach. So we stop, and the antegrade, I said, okay, I failed the antegrade. Now if you remember that we have a good dorsalis pedis with anterior tibial system, so I did an ultrasound puncture of the dorsalis pedis, and I managed to go all the way up to the, with an 014 wire, up to the popliteal artery, which you will see it in the second picture now. And you can see here on the top that my wire of the antegrade, I just park it there so that I know where I am, and I try to reconnect. So this is the wire going retrogradely from the dorsalis pedis up to there, and you will see the dye hanging there. That's the area where the occlusion is. So I need now to connect this wire retrogradely with the anterior. So I took the microcatheter from the top and I tried to push it from below, and this is where I connect both together. And this is where I am externalizing my wire into the sheath. Now in the sheath here, when you have a big common femoral, this is my sheath. So I took a guide here just to engage with the ostial of the SFA, where I can get my wire. So every time the wire keeps going into the, because it's a bigger lumen, so it will go to the side. Then this is the time that you need just to be patient and try to manipulate slowly. And this is where I try to manage later on and go inside the guide, then into the sheath. Then I externalize with the microcatheter all the way inside the sheath, just to maintain a good support, and push my wire all the way and externalize it from the contralateral side. So I have full wire from the dorsalis pedis all the way to the contralateral. I switch that with the 035 microcatheter now, so that I push a microcatheter, push an 035 wire, and then I start ballooning from the relatively healthy area back to the ostium with a 5-0 balloon all the way. And then I checked it was a good flow, so I finished my pre-dilatation with a DCB. So I've used a DCB in all the SFA, and I got this result at the end. So this is the ostial SFA up to the mid, and then the second picture will show you the flow in the up to the popliteal. Now, one of the things that because we as a cardiologist, we like to watch, monitor pressures and so on and so forth. So this is actually the first graph is the pressure from the sheath where this is the systemic pressure of the patient, 150, and this is the dorsalis pedis pressure before revascularization. And after the revascularization, you can see both lines are identical on top of each other, which means that the gradient has been removed completely. Post-procedure, the ABI patient, first of all, ABI almost 1. Patient does not have any claudication afterwards. I usually monitor these patients for the groin complications issues overnight, and then I put the patient on dual antiplatelet therapy plus the rest of his medications, and then discharge him. I followed the patient, and 3 months later, he came. He was completely asymptomatic from the right side, and he's doing his daily activity with maintenance of the ABI. I usually check the ABI when they come to me, even if they have no symptoms, and the ABI was 1. That's it. Thank you.
Thank you,
I think
Fawaz. Yeah, go ahead.
Sorry, I was just going to say, I think that's a really excellent case that highlights a lot of points that we've tried to emphasize through the guidelines, from medical therapy to exercise, all the way through revascularization and follow-up. So that's wonderful.
Thank you.
We have a panelist, Dr. Muhannad Al-Mubarak. I'm wondering if he has any comments on the guidelines or on the case.
Well, thank you, Dr. Can anyone hear you very well?
Yes, we can hear you.
Okay, good. I'm in a wedding ceremony now, so I'm probably the only one speaking English while everyone around me is speaking Arabic. So I apologize for that. One thing caught my attention in the guidelines, maybe something similar to the ACS guideline. Why our European colleagues, they feel like in STEMI they don't recommend upfront heparin therapy in STEMI. Now in ALI, it feels very similar, and although disease process is very similar, so we have thrombotic lesion. So this is the only thing caught my attention. I don't know why the downgrade in the upfront heparin therapy.
And your comment is specifically in reference to the acute limb ischemia, sort of the PAD equivalent. Yeah. I mean, I can't comment on the European Society side. I wasn't involved at all in that guideline document. I think we treat on the ACCHA side in the US, we would treat with upfront heparin in both of the scenarios you mentioned, both ACS and ALI. To be fair, I don't know that we have much in the way of randomized data looking at that, right? I think that's just been the way that we've done it for a very long time, and it's become the standard. But if we want to be really strict about it, I don't know that there are many randomized trials of heparin versus no heparin, as an example, in ALI. I think it's sort of like there's no randomized trials for whether you need a parachute when you jump out of a plane. We just assume you do.
Yep. I think, thank you. Any closing comments from Batul, Fawaz, and then I will leave it to Herb to close off the session.
Sure. I have a very important closing comment to say. So I think given the fact that I'm the only vascular medicine consultant in the Middle East so far, I just want to stress on the fact that those guidelines gave a very particular attention to risk factor reduction, risk factor modification, and this is what we do in vascular medicine. So this practically gives us a hint that we need more vascular medicine experts in the region. We need more people that do this in order to improve detection, diagnosis, screening of those patients, and also optimizing those patients. So I think this is something very important for us to spot a light on, especially in the region that we are practicing in. Those patients' population, they need a lot of care. A lot of those patients have no access to healthcare. On the other hand, there is a huge lack of awareness that we need to be working on a lot.
Actually, those are very good points, and congratulations being the first vascular medicine consultant. When I came back from US, I was planning to take the SVM exams, but then life just got too busy. So I think my advice to anybody who's in their fellowship is to finish everything before finishing, because once you start your practice in your life, things can get extremely busy. The point about vascular medicine in Middle East, and this is something we never faced much in US, but here it is something that is absolutely divided amongst vascular surgeons who think this is their domain, and they're extremely protective of their turf, interventional radiologists, and some cardiologists. Mirvat and I work in the same hospital. We used to have a very high volume of vascular patients, especially below knee, because then the newer generations of vascular surgeons wanted to take it over. So I think that's one of the issues we do face, that it is something divided amongst these specialties, and everybody sort of protects their turf. And I think we always talk about it, and at least we have talked about it for the last decade, of working together. And it's probably easy in Fawaz's place, where you have one large center that's covering. The city I work in has 26 cath labs and everybody doing their thing. So it's kind of gets a little complicated.
Sorry, go ahead.
Sorry, Dr. Ahmed, if you're interested in vascular medicine and being a part of vascular medicine, our SVM society has like a huge niche for international folks who are interested in joining, and we're always welcome to have more people join us aboard. So I can talk to you about this later, but you're more than welcome to be a part of it. It's a great society to be a part of.
Yeah, thank you, Batul, for making that plug on behalf of SVM. That is a growing segment of our membership that I think we really appreciate. So yes, not just the panelists, but anyone who happens to be listening, Batul can tell you more.
Absolutely, would love to.
I think this when I came back here, especially this region, I did not appreciate the amount of peripheral vascular disease that we have. The problem is not only the peripheral vascular disease, but also the type of patients. Now, out of 10, you at least get 7 of them who have renal failure with very bad disease. And the problem is, for example, the case that we share is a very straightforward, nice case, but most of the problems comes for the microvascular disease. And these are the challenging ones. You open the big highways, but then again, you end up with still some deficits in the microcirculation. That's number one. My second challenge, and this goes to Batul's also point, is the education. So the patient, when he sees all this effort, you stay with him 3 hours in the cath lab, and then you finish, he said, yeah, I promise you I'm going to quit smoking. You see him in 2 weeks' time in the clinic, he said, I couldn't stop smoking. So he comes and he continues to smoke. The third challenge in this community here as well is the teamwork. So if I open the artery, for example, it's not one-man show. It has to be a diabetic foot specialist who take care of the wound, has to be education from the vascular team. It has to be that thing. We don't have it here. Now, this is aside from, whether who wants to take it, intervention radiologist or vascular. For example, in Bahrain, I have received this case from a vascular surgeons. So we cooperate. If they fail, they send it to me. If I cannot do something, I send it to them. But it's more about the teamwork and the education for the patients, because we have a lot of patients who are suffering from this. And mind you, to the first sentence, I remember, Batul, you mentioned in your first slide that a lot of these patients are hidden. They have no symptoms. They pop up after a few years with, for example, a gangrene in their big toe. And then this is where the challenge starts.
I have a question from one of the audiences. So if Herb, can you take it, or Batul? Are beta blockers contraindicated in peripheral vascular disease?
I think Batul and I are probably going to give you the same answer, which is no. There was a time really decades ago when theoretically there was concern that beta blockade would leave unopposed alpha agonism and vasoconstriction, and that would be a bad thing in these patients. But that hasn't borne out. There have been a number of studies that have looked at this, mostly observational data, but there really isn't felt to be a harm. So if there's an indication for your patient to be on a beta blocker, you don't have to avoid that just because they've got PAD.
Going back to diabetes for was, what a lot of people do not appreciate outside our region, we have one of the highest rates of diabetes in the world. 40% of our walking population, 40% of our adult walking population is pre-diabetic or fully diabetic. People entering my cath lab, unless they're very young, heavy smokers, everybody's a diabetic until proven otherwise. And I have arguments with patients. They say, oh, doc, we're not diabetics. So I show them their hemoglobin A1C is now 6.9%, like you're diabetic. And the funniest thing is I did a double CTO in a patient on Wednesday. Thursday in morning rounds, I went to his bedside and he had 2 Kit Kats, 1 Twix, and a Snickers bar. So for us, you know that we will see these patients again.
Unfortunately, yes. I do have a question, if I may ask here. What do you think about the new generation of the diabetic medication, Jardiance, is GLT2 and peripheral vascular disease? I'm talking about those patients who have critical limb ischemia. Because there is something that says, like, using this medication in this type of a group of patients may worsen and may end up by losing their limbs. And this is like, critical way of thinking.
Yeah, there was, I'm happy to comment. Others may want to say something too. I think there was some early data with canagliflozin that was where there was associated gangrene and limb loss. And in fact, it prompted the US Food and Drug Administration to issue what we refer to as a black box warning on that agent. That was later removed because mounting evidence suggested that actually that risk, if present, is extremely low and would be outweighed by the benefit of the class of medications, or specifically that agent. So today, I think, at least in the US and per the US guidelines, and we speak to this a little bit in the supporting text, we see no reason why not to use these agents as a class, including canagliflozin, in patients with diabetes and PAD.
Thank you.
Right. I think unless we have some urgent comments or questions, we're getting close to the 8:30 hour. So I'd like to thank all the speakers and the panelists for your time. And we can close the session. Thank you very much.
Good to see everybody. Thanks so much.
Thank you, everyone.
Thank you.
Bye.
Bye-bye.
Thank you.
Who's going to win, Michigan or Ohio?
Unfortunately, this year it may be Ohio State, as much as I'd like to see that happen to Michigan.
Yeah. All right. Good night.
All right. Thank you. Bye-bye.